Hello everyone, I am Mukesh, a second year MBBS student from GMCS Sundargarh. Today I am going to discuss one of the important topic from the hematology from physiology book of first year MBBS. And this is very important for the university examination as well as for the conceptual learning. It is one of the basic fundamentals things for the further learning of your MBBS. So let's begin hematology. And first of all, I will convey what I'm going to discuss on this. That are the topics like bloods, plasma proteins, hemoglobin, RBC, anemia, jaundice, WBC, platelets, blood grouping, blood transfusion reaction, and coagulation of the bloods. So let's begin. First, the blood. What is blood? Blood is the liquid components or the loose connective tissue of our body that constitute about 8% of the body weights. So if person is 70 kg weights, then if you multiply the 8%, that will comes out to 5.6 liter, and a normal blood volume is 5 to 6 liter, whereas the viscosity of the blood is 4 to 5 times of that of water, and pH is slightly alkaline. Let's classify the bloods. Blood is classified into two types. One is form element and another is plasma. Form element constitute 45%, whereas the plasma constitute about 55%. And form element is of three types. One is RBC, WBC, and platelets. As you also know the counts and the normal range. And see about the plasma is constitute about 91% of water and 9% of solid material, which the 9% solid material again divided into inorganics and organics. Inorganic constitute 1% and organic constitute 8% of the 9% of solid material, whereas it constitute of plasma proteins and other materials like glucose, fats, lipids, and hormones and enzyme etc. etc. Okay, if you say about the plasma proteins, it is of albumin, globulin, fibrinogen, and prothrombins. There are other plasma protein also present in the blood, but they are very trace amounts. So basically, consider these four as a plasma protein. Let's see about the function of blood. That is respiratory function. Transport of the gases is the major function of the blood. Second is the nutritive function. Transport of the amino acid, glucose, fat, and minerals from their site of origin to the distinct sites or the site of absorption. Okay, like this. And excretory function like urea, uric acid, creatinine, etc. to their respective site of elimination. Homeostasis for the water, pH, and electrolytes, as well as regulation of body temperatures by vasoconstriction and vasodilation. Like this, what happen actually in our body. And the next is a defense mechanism by WBC and coagulation by the platelets. So let's see what is serum. Serum is nothing but blood minus clotting factor in general. What if you say about in this way, that is blood minus fibrinogen plus clotting factor 2, 5 and 8, because other clotting factor get utilized and these are present. So serum has a high concentration of serotonin because of breakdown of platelet. As you know, the platelet contains serotonin. Let's see plasma proteins. Plasma protein is nothing but the protein. Okay, plasma protein in embryo, it is synthesized by the mesenchymal cell. The first is albumin, fibrinogen alpha and beta globulin, and a gamma globulin, where the albumin and fibrinogen are synthesized by the liver. Alpha and beta globulin are the tissue macrophages, and the gamma globulin by the plasma cells. And if we say about the different form of globulins, that is glycoproteins, lipoprotein, transferrin, haptoglobin, cytoplasmin, angiotensin, these all are the forms of globulins that have a role in our body. And let's see one of the important plasma protein, that is albumin. Albumins decrease levels in physiological condition like infancy and childhood. Decrease level of albumin because of there is hepatic immaturity. As you know that liver is the primary organ for the production of albumin. Similarly, in pregnancy decreases albumin levels, and in pathological like liver diseases, malabsorption, kidney diseases, nephrotic syndromes, and bones, like this condition where the level of albumin decreases. And if you say about the function of plasma proteins, that is help in the coagulation of bloods, there are many clotting factors. And also one of the important concept, that is help to maintain the blood colloidal osmotic pressures. This is one of the important and examiner's favorite points to ask whenever they ask about the plasma proteins. That is oncotic pressure on the capillary can be due to crystalloid, example urea, sodium, and glucose, and colloid, example plasma protein. Listen one things, crystalloids never apply the osmotic pressure because they can be applied, but they actually not apply because they are permeable to the capillary membrane. That's why they will never consider crystalloid. And where is the osmotic pressure is due to the plasma proteins, so they are called colloidal osmotic pressures. And here is the one hypothesis, that is Starling hypothesis, that gives the relationship between hydrostatic pressure and the blood colloidal osmotic pressures, how they are related to each others, and how actually the fluid exchange between these capillaries takes place. That explained by the Starling hypothesis. Hydrostatic pressure is due to pressure of waters which present inside the capillary, that is pressure outside the capillary. And the colloidal osmotic pressure is a pressure which from outside to inside, that means interstitial space to the blood vessels or the capillary is by blood colloidal osmotic pressure. That means it is responsible for the absorption of water, whereas the hydrostatic pressure is responsible for the leakage of the water from the capillary. So there are two things, one is the arterial ints and one is the venous ints, where the arterial in actually filtration or the leakage of liquid take place. Because this happens where the hydrostatic pressure is higher than the colloidal osmotic pressure. Here I have taken colloidal osmotic pressure is 25 mmHg, where the hydrostatic pressure is 35 mmHg. The net pressure gradient is 10 mmHg. That means there will be the movement of the waters from the vessel to the interstitial space. And in venous ints this is reverse, there is the colloidal osmotic pressure is higher and the hydrostatic pressure is low. As we already know that hydrostatic pressure is due to the waters, that means if water get leaked out in the arterial int, and there will be the less content of water in the vessels or the capillary, that causes decrease in the hydrostatic pressure. That is, there will be the compensatory there is no increase, actually there will be the, that means hydrostatic is lesser than the COPs. That's why water get reabsorbed through the venous ints, and like this water electrolytes, water balance it takes place in the capillary. Okay, this is one of the important. And if this balance is disturbed, that result in the edema. If there will be decrease in the colloidal osmotic pressures or there will be increase in hydrostatic pressure, that causes edema formations. Okay, so COP is mostly due to albumin, as you already know. So in liver disease, COP and albumin decreases, albumin synthesis cannot possible, that's why edema results. Similarly in kidney disease like nephrotic syndromes, there will be the leakage of the albumins from the kidney, that causes decrease in the albumin level in our body, decrease in the COP, result in edema. Like this most lacks in the reasoning type of question when liver diseases edema is seen like this. Also plasma proteins helps in the maintaining the viscosity of blood. So viscosity depends on the shape of protein mainly. If there will be the irregular shape of the protein, there will be more viscosity of that proteins. So if you say about the albumin and the fibrinogen irregular shapes, that's why they provide more viscosity to the blood, but their quantity is lesser. That's why albumin is also provide the viscosity to the bloods. And they have also buffering action of albumin is due to histidine present in the albumins, and transport function like hormone drugs etc get transported by the albumins. This is one of the important function of the plasma proteins. Let's see next, that is the hemoglobins. One of the important and the most conceptual things to learn about the hemoglobin, that hemoglobin is nothing but heme plus globin, whereas the heme is non-proteinous part and the globin is the polypeptide chain. Let's see what is actually heme. Heme is actually iron containing porphyrin ring. Iron plus porphyrin ring is nothing but heme, whereas they contain tetrapyrrole ring. That means these structures are the four these nitrogenous bases with this ring structure are called the pyrrole ring, whereas iron get binds with nitrogens, and these are the bridges which convert this a name and alpha beta delta gamma like this. No need to memorize this structure, just you should know that heme contains one iron and the four pyrrole rings, tetrapyrrole rings. And this one heme structure is concentrated with one polypeptide chain of hemoglobin. So in adult hemoglobin we have a four polypeptide chains, two identical alpha and two identical beta. That's why they contains four irons, and four irons molecule is this structure. So one hemoglobin molecule can binds with the four molecules of oxygen. Actually what happens, see, this iron binds with the four nitrogens, and another bond it will form with the protein part of the polypeptide chains, mostly histidine. Okay, and the rest one bond, as you know that Fe plus 2 is, that is valency of 6, so she can bond 6 bond can form. So, but here is already 4, and one bond will form with the peptides of the beta chains. The rest one which is present free, that is actually responsible for the binding with oxygen. So one hemoglobin molecule can bind with 4 molecule of oxygens or the 8 atom of the oxygen. This is actual the things you should learn about the hemoglobin. Here are some terminologies: oxyhemoglobin, deoxyhemoglobin, carboxyhemoglobin, and carboaminohemoglobin. As you already know about this, I'm not going to say about this. And the methemoglobin concentration concept, where the Ap plus 2 is converted into Ap plus 3 due to oxidizing agent. If it's greater than 5%, it causes cyanosis. There is the bluish discoloration of the tip of the like the tips of the fingers and the tongue like this will be occurs. And if you say about the free hemoglobin was a dangerous hemoglobin that can be was cause hazardous impact on our body. Where the free hemoglobin actually, when the hemoglobin dissolve in plasma called free hemoglobin, disadvantage this decreases increases the viscosity of the blood, as you already know, increase in the blood pressures as well as increase oncotic pressure, like this damage to the kidney. Free hemoglobinuria like this. That's why free hemoglobin is not possible to be present in our body. Okay, so next is the catabolism of hemoglobins. Catabolism of hemoglobin is by the reticuloendothelial system, and here the reticuloendothelial system, the hemoglobin is converted into globin and heme, where heme is converted into the irons and porphyrins. Porphyrin is the converted into bilirubin, biliverdin by heme oxygenase and bilirubin reductase, and here the iron is goes to the ferritin, and globin is go to the amino pool, and a free hemoglobin is bind to haptoglobin. So if there will be the intravascular coagulation that causes intravascular, not coagulation actually, intravascular hemolysis যদি ହେଉଛି, then the hemoglobin bind with haptoglobin and there is a decreased level of haptoglobin in the bloodstream. Okay, so types of the hemoglobin is say that is adult type HbA alpha 2 beta 2, fetal hemoglobin alpha 2 and gamma 2. Why fetal hemoglobin has a more affinity for oxygen? This is because of the poor binding of 2,3-ppg to the gamma chain of the fetal hemoglobin that causes. Actually, what happened is this: see, 2,3-BP is responsible for the delivery of the oxygen to the tissue sites. If it is poorly bind, that does not cause to oxygen to binds poorly to deliver the tissue site. That causes increased affinity for the oxygens of the fetal hemoglobin, and also it is one of the reasons behind for this. That's why fetal hemoglobin has a strong affinity for oxygen. That it can takes oxygen from the maternal blood to the child's. Okay, this is also one of the important concept of the fetal hemoglobin. And if you say about the hemoglobinopathy, that is affecting the globulin chain, sickle cell anemia are called the hemoglobinopathy. Let's see RBC. RBC is circular and biconcave, and because of biconcave and circular shape, we can trend with change in the osmolarity. That means if there will be the hypotonic solution of the blood, hypotonicity of the bloods, then it can withstand a larger volume to expand, and easy folding of RBC when passing through a capillary. Hemoglobin remain equally distributed and easy to exchange of the gases like this. And lifespan is 120 days rela. If you say for the adult male 5 to 6 millions, where the female is 4 to 4 and child is 6 to 8 millions. And hemopoiesis is the development of all blood cells. RBC erythropoiesis, WBC is leukopoiesis, and the platelet is called megakaryopoiesis. There are two theories which explain the hematopoiesis. One is the monophylactic theory, which causes all the blood cells are come from the one single pluripotent stem cell, whereas the polyphylactic theory says that all the precursor of all the form element of blood cells are come from the different type of stem cells. But most acceptable theory is the monophylactic theories, where it says that pluripotent stem cells or the hematopoietic stem cell converted into lymphocyte precursor lymphoid cells, where the committed stem cells converted into myeloid stem cell, and the erythroid stem cell. Erythroid stem cell gives rise to RBC, whereas the myeloid stem cell gives rise to WBC and platelets. Let's see erythropoiesis, one of the important LAQ for the university examinations. And erythropoiesis is the formation of RBC from hematopoietic stem cells. And if you see about the stages of erythropoiesis, there are three stages. One is called mesoblastic stage, which is seen in the intrauterine lives, and hepatic stage, and the next one is the medullary stage. Okay, so intrauterine life, in intrauterine life, mesoblastic stage, height is Yoxx, and the area vasculosa, mesoderms, up to 3 months. And after 3 to 6 months, hepatic stage, where spleen and the liver are the site for the hematopoiesis or the erythropoiesis. And medullary stage, after the 5th month, the bone marrow start. In bone marrow, blood formation is started. And the site of erythropoiesis in children, all the bones with the red bone marrow, liver and spleen, whereas the adult end bones, the long bones, femur and humerus, and the scapula, sternum, pelvis, skull are the flat bones where the erythropoiesis takes place. And if you say about the steps of the erythropoiesis, that we I think you should already know about this. That is a hematopoietic stem cell erythroid series, and pro-erythroblast, early erythroblast, intermediate erythroblast, late normoblast, and the reticulocyte and the RBC. These are the steps of the erythropoiesis. You should draw a structure of this for the exam point of view. I haven't drawn this. And if you say about the others name of the early normoblast, that is basophilic, and this is polychromatic, and the orthochromatic pneumonic BPO. You will memorize like this. And let's see the regulation of erythropoiesis. Most important one is the hypoxia, and second is the specific maturation factor, slide dietary factor, castle intrinsic factor, extrinsic factor. Like this will be responsible for the production of the RBC. Here the hypoxia, lack of oxygen, most potent stimulator for the erythropoiesis. Actually, what happens when there will be lack of oxygen to the tissue, that causes the formation of hypoxia inducible factors HIF, that is responsible for the release of the erythropoietin from the kidney, and erythropoietin is one of the important stimulator for the erythropoiesis. And here the committed stem cell is converted into pro erythroblast. This step is accelerated by the erythropoietins. And if you see about the dietary factors, like proteins help in the globin synthesis, iron, copper, manganese help in the iron is also important for the erythropoiesis, like calcium increase absorption. Intrinsic factor furnishes anemia, vitamin B12, folic acid. Like this, all factors are responsible for the production of the erythropoiesis. And other like factor interleukin, colony stimulating factors help in erythropoiesis. You should learn about the interleukin 1, 6, and 13, and also colony stimulating factors. These are for the higher classes. Let's see next one, that is anemia, one of the important LQ for the university examinations, and mostly asked or frequently asked this is. And for the Ekigen, anemia is the clinical condition characterized by the reduction in the number of RBC less than 4 millions per microliter, or their hemoglobin less than the 12 gram per deciliter, or the both. This is anemia definition what given by the Ekigens. And if we divide into anemias in the grading system, mild anemia 8 to 12 gram per deciliter. What is the moderate one is the 8 to 12, and this is 5 to 8, and the severe one is the less than 5. Okay, also the definition depends on the sex, male or female, age, and physiological status of the individuals. Like words, as we already know, the female has less concentrated hemoglobin or the RBC, that's there the definition of anemia may change. And physiological status, if there's any comorbidity, and then there will be the less hemoglobin, so there we cannot consider like normal things what we will consider for the anemia. Also in age and old age and child has more number of RBCs, that means we cannot consider this like anemia, like things that's overall. Okay, so clinical findings, okay, this is something clinical data what you should know about this. Exertional dyspnea, that means difficulty in breathing when the person is doing exercise, that is less than 7.5 gram per deciliter of hemoglobin. Weakness less than 6 grams. Dyspnea at rest less than 3 gram per deciliter. If there will be severe hemoglobin decrease, that is less than 2 gram per deciliter, that causes heart failure. Like this you should know about this, nothing else. And the classification of anemia, anemia is mostly classified under two bases. One is etiological classification, which is also called Whitby classification, and another is the morphological classification. This is called Winthrop classification. And on the basis of etiological classification, it is based on the etiology of the cause of anemia. There are many divisions like this. What blood loss? If there will be blood loss, that results in anemia. It can be of two types. One is acute blood loss or the chronic blood loss, where acute blood loss mostly due to accident or the automobile accidents or the trauma, whereas chronic blood loss is a hookworm piles during menstruation. Like this chronic blood loss occur. Okay, and if you see about others, like what dyshematopoiesis, that means there will be defective hematopoiesis, that is known as aplastic anemia. This is a very important one of the aplastic anemia, that is the hypocellular of the bone marrow, and there will be no production of any blood cells. That means there will be defect in the RBC, WBC, and platelet. Nothing will form in aplastic anemia. Okay, and if there is a dietary defect, IDA and the megaloblastic anemia, iron deficiency and megaloblastic anemia, hemolytic anemia, the anemia, this will result in the hemolysis of the bloods. There is two types. One is intracorpuscular defect, and another is the extracorpuscular defect. Whereas intracorpuscular defect is due to G6PD deficiency, hereditary spherocytosis, thalassemia, as well as sickle cell anemia. These have the intracorpuscular defect or the intrinsic defect of the RBC. What is the extracorpuscular defect? There is extrinsic defect of RBC, like antigen antibody mediated like ammonia. There are some ammonia will run in the further classes that comes under the antibody antigen mediated ammonia. And infection like malaria and certain drugs, you know about this. Certain drug also called anemia. Next is the morphological classification. It is based on the size of RBC and hemoglobin concentration. Mostly the concentration of hemoglobin never increases in anemia, as you already know. So there are two. One is normochromic and another is hypochromics. And divide the size onto the three types. One is normocytic, microcytic, and macrocytic. So you should memorize that a microcytic anemia there are four. One is iron deficiency anemia, thalassemia, anemia of chronic diseases, and okay, there are three here given, and also another one is sideroblastic anemia. This comes under the category of microcytic anemia. Okay, so here the macrocytic anemia is macrocytic normochromic, that is megaloblastic anemia, and there is secondary cause to liver. You should know. I don't think so. You should remember this. This you should know. Macrocytic normochromic anemia, normocytic, and normocytic normochromic acute blood loss, all hemolytic anemia except thalassemia, where thalassemia is microcytic hypochromic, and the normocytic is the chronic blood loss hypochromic. This is the morphological classification or Winthrop's classification. Let's see some important anemia like iron deficiency anemia. It is the most common cause of anemia worldwide as well as India. Any anemia which responds to adequate dosage of iron is called IDA. And there are four causes mainly due to iron deficiency. One is the dietary, another is malabsorption, increased demand, and the increased loss. Like these four causes of the iron deficiency anemia. So characteristic is what you will get microcytic hypochromic RBC in the peripheral smear. There will be the decreased size of RBC, and we'll compare the size of RBC with the lymphocytes, and generally the lymphocytes has a similar size of that RBC. If the RBC size is lesser than the lymphocytes, that we call it the microcytic RBC, and there will be the pallor. Actually what happens, RBC outer two third is concentrated with hemoglobin and central one third is pallor. Okay, so if outer one third is concentrated, there will be a decrease in the outer two third level of the hemoglobin, that is known as hypochromic. So microcytic hypochromic RBC, MCB, MCH, MCSC will be decreased, and isocytosis and poikilocytosis, as we already know the different shape and size of the WC, not WC, RBC seen. Biochemistry finding is serum protein level will decrease, serum transferrin level, TIVC total iron binding capacity will be increased, and serum iron is decreased. Most important reliable indicator serum protein, which is storage from the irons, and this is the lymphocyte and micro and RBC, where the microcytic hypochromic RBC is present in the idea. Let's see another anemia, that is megaloblastic anemia. Megaloblastic anemia is nothing but macrocytic RBC, that may increase the size of RBC, and it is mostly due to the folic acid and vitamin B12 deficiency. And folic acid deficiency like similar that increase in dietary intakes, malabsorption, increased demand in the pregnancy, and antifolate drugs like methotrexate, as you already you know this about this methotrexate. Okay, and vitamin B12 is pernicious anemia, autoimmune diseases, dietary intake is decreased, and malabsorption like this causes the vitamin B12 deficiency. And also one thing is confirmed that if there will be the deficiency of the vitamin, if there will be deficiency of vitamin B12, that causes neurological manifestation. But if there will be deficiency of folic acid and causes anemia, there will no neurological manifestation. So know this. Okay, and folic acid and vitamin B12 required for the DNA maturation. So if they are deficient, leading to the nuclear maturation lag behind cytoplasmic maturation, so there will be the increased size of RBC, and there will be no defect in the hemoglobin synthesis. Okay, one thing here, there will defect in the nuclear maturation, not in the not in the hemoglobin. So there will be the normochromic, there will be no hypochromic. Okay, normochromic megaloblastic anemia, like this presentation will be in the pernicious. And another one is the pernicious anemia, that is autoimmune anemia. Autoimmune disease, like what actually happens, autoimmune attack the parietal cell, that is responsible for the release of the SCL as well as the intrinsic factor, and intrinsic factor is responsible for the absorption of vitamin B12. If that get defects, there will be no absorption of vitamin B12 from GIT, that result in the vitamin B12 deficiency, and that vitamin B12 deficiency result in the pernicious and not pernicious anemia, not megaloblastic anemia. Okay, like this actually happens. And next in the hereditary spherocytosis. Hereditary spherocytosis, that's nothing but defect in the cytoskeletal protein of the RBC, that causes in the defective in their cell membrane of the RBC, that causes changes of the compared to spherocytes, that means spherical RBC, and spherical RBC is in the hereditary spherocytosis, that is genetic defect of this. And the next is the thalassemia. Thalassemia is the quantitative disorders, where is the hemoglobinopathy, where the sickle cell anemia is the qualitative defect, where the thalassemia quantity of the hemoglobin is defect is two type. One is the mostly three type, we will categorize thalassemia into three category. One is the thalassemia major, intermediate, and the thalassemia minors, where the major is the most fatal and the most dangerous, where the repeated blood transfusion required. Whereas the intermediate, there will be less transfusion of the blood requires, and in case of minor, that is asymptomatic, that not causes any kind of disease. Okay. And if you say about the sickle cell anemia can be of two type. One is the traits and one is disease, where disease repeated blood transfusion also requires. And also one thing you should know that in thalassemia the death of the person or the patient occur because of iron overload. Okay, iron overload is a major cause, as you already know that if we take in the repeated blood transfusion, that iron get metabolized in our body, that cannot excrete as per the normal process. So that's why iron overload causes the disease. And also you will learn in further classes that iron causes hepatotoxicity, cardiotoxicity like this, and that's why the death occur in the thalassemia patients. Okay. Let's see next important clinical aspect of the hematology, that is jaundice. Jaundice is one of the important topic that must ask question in the university examination. And jaundice is defined as the yellowish discoloration of the skins and the mucous membrane due to increased level of bilirubin in the bloods. And the main cause of the jaundice is increased bilirubin in the blood. And also one thing is that normal level of bilirubin to 0.2 to 0.8 milligram per deciliter, and latent jaundice is that mostly 1 to 2 milligram per deciliter. There will be no symptoms of the jaundice seen from physically. That is called latent jaundice. Latent means what? Hidden. There is been no clinical manifestation of jaundice. That is called latent jaundice. And if it exceed more than the 2 milligram per deciliter, that causes clinical jaundice, or the jaundice symptoms start to appear. Okay, the first sign of jaundice seen in the sclera, yellowish discoloration, because they last in protein. Okay, one thing is you should know that why there will be the yellowish discoloration sclera. Sclera has a protein that is elastin protein, and elastin protein has a higher affinity for the bilirubin bindings. That way, the first sign of the yellowish discoloration seen in the sclera. Okay, if we classify into the jaundice into three types, one is pre-hepatic jaundice, hepatic jaundice, and the post-hepatic jaundice. And let's see what the comparison between these three. Okay, pre-hepatic jaundice, hepatic jaundice, and the post-hepatic jaundice. Where the pre-hepatic jaundice is also called hemolytic jaundice, where the obstructive jaundice is called obstructive jaundice, is called post-hepatic jaundice. Okay, there is no as such. And here is the Vandenberg test. One test is done for the identification, but no identification other way also you will get this. Here are the direct positives, and here is the biphasic response. Here is the indirect positives. Okay. And I think you should know about this Vandenberg reaction from the biochemistry, and I'm not going to discuss about this, so you should memorize this. Okay. And the cause is all hemolytic diseases, excessive breakdown of the RBC. Here is the viral or bacterial damage to the liver. If there will be any defect in the liver, if liver is unable to metabolize the bilirubin, that causes in hepatic jaundice. Okay, there is no such other one. Okay. And here the post hepatic jaundice due to the common bile duct stone or the tumor of the head of the pancreas that causes obstruction of the bile flow to the intestine, and there will be the increase in the conjugated level of the bilirubin. Okay, so if you say about the color of urine, here the normal color of urine in pre-hepatic jaundice, and what is the dark yellow in the hepatic jaundice because of bilirubin excretion, and what is the more dark in the post-hepatic jaundice where the conjugated bilirubin is more excreted. Okay, stool color here the brown to cercobilin, here the less brown, and the clay color stone rail. Okay, here the clay color, there is obstruction, there will be no upcoming of the bilirubin to the intestine. So if not come to the intestine, how it will go to the feces? Okay, that's why there will be the clay color stool in the post hepatic jaundice. Okay. And if you say about the urine urobilinogen responsible for the coloring of the urine, so this is present in the pre-hepatic jaundice as well as the hepatic jaundice, but not in the post-hepatic jaundice. Okay, so after the surgery or anything due to treatment of post-hepatic jaundice, if you will check urine, if you're getting urobilinogen urine, that means post-hepatic jaundice is, or the surgical jaundice also it is called, and the post-hepatic jaundice is treated. Okay, if urobilinogen not come, then there will be again defect in the system. Okay, alkaline phosphorus has the normal it is 0 to 2 time increases, where the 10 to 14 time 10 to 14 or 12 times increases. Okay, liver enzyme sgpt sgpt like this, ggt and like this. Okay, here the normal elevated, and there the normal. If there will be defect in the liver, that causes elevation in the liver enzymes, simple. And here the normal will be the livers, here the impaired, and another normals are the mild impaired. Okay. And also one another things, that is physiological jaundice. Physiological jaundice nothing but the jaundice of the newborns, and mostly seen the preterm baby. Okay, here what happens due to the excessive breakdown of the RBCs and immaturity of the liver that cannot metabolize the excessive breakdown of the RBC that causes bilirubin. Okay, so if it greater than 20 milligram per deciliter, then it causes like connector salticea, etc. Okay, but generally subsided by itself. If not possible, then we give phototherapy, whereas the bilirubin is converted into lobirubin, that is less toxic one, and that gets treated in the urines. Let's see next one, that is WBC, one of the important things of our blood component. where we will discuss about the WBC. And WBC is two type. One is granulocytes, and the next is agranulocytes. What is the granulocyte? Is the neutrophil, eosinophil, and basophils that contains granules, and agranulocyte are the lymphocyte and monocyte that does not contains any granules. Okay, so total leukocyte counts is 4,000 to 11,000 per microliters, and leukopenia is nothing but decrease in the WBC more less than the 4,000 per microliters. Cause is starvation. Type most important one is typhoid and paratyphoid fever. You should know this. Viral and protozoal infection, bone marrow suppression. You write bone marrow suppression in every decrease in cell counts. Okay, like in RBC, if there will be decrease in RBC, there will be decrease in platelets, there will be decrease in the WBC. You can say like bone marrow suppression. One of the reason is okay. You can say like this. Leukocytosis, where there will be increase in the WBC count that is more than the 11,000 per microliter. Physiological condition like newborn in the evening, exercise, stress, pregnancy, lactation, menstruation. These are the causes of leukocytosis. Physical, what is the leaky, and the pathological is any pathogenic infection. Mostly pus-forming bacteria causes increase in neutrophil. Okay. Increased neutrophil also in WBC. Okay, leukemia is nothing but increased WBC count with immature WBC in the peripheral smear. Okay, listen one things. Leukocytosis is increase in WBC counts. Okay, but that are mature one. Okay, but increase in WBC counts with immature WBC, that is called leukemia, and it is a blood cancer. Okay, you will learn it's about in higher classes. And let's see neutrophils, one of the important polymorphonuclear cell like this. You can say color is purple, granules is pink, nucleus is multi-lobed, 2 to 5 lobes is generally present, and maturity is in depend on the number of lobes. Okay, if there will be the higher number of lobes, that is more mature one. Okay, function first line of defense, phagocytosis, inflammatory mediators. So neutrophilia increases the number of neutrophil like this. What exercise after injection of epinephrine, pregnancy, lactation, menstruation, and acute pathogenic infections, tissue destruction like bonds, MI, and surgery like this. Also, you know that neutrophil is the inflammatory mediators here, right? So, if there will be any inflammation to the body like bones, MI, and the tissue injury, that must neutrophil goes there, and also it's the first line of defense. That means first anything happens to our body, it will go there, and the increase in number, that is called neutrophilia. And the next one is neutropenia. What decrease the neutrophil? Mostly the typhoid and paratyphoid fever. You should memorize bone marrow suppression and children 40% around present, but generally what 50 to 70% present in the adult. Okay, so like this, even viral infection is there. And eosinophil is something like what Greek reds granules, and purple color bilobed nucleus in 85%, also trilobed nucleus in last 15%. Okay, so that is not actually important. Remember this. Okay, eosinophil mostly increase in the allergic and parasitic infections. You should memorize this. Allergy and the parasitic infection most causes of increase in eosinophil counts. Basophil is the contains okay, granules, and the mostly in the CMI. Chronic myeloid leukemia is one of the most cause of the basophilia. Chickenpox, smallpox, tuberculosis like this. Okay, and here also the eosinophil count decreases in the what after administration of glucocorticoids. And lymphocyte are the large lymphocyte and the small lymphocyte, clear cytoplasm, lymphocyte in children, chronic infection, increased lymphocytosis more children, lymphocyte more than neutrophils, lymphocyte. Okay, lymphopenia aids in the bone marrow suppression of the causes of the, and monocyte the largest WBC, cytoplasm pale staining, clear acentric nucleus, kidney shaped nucleus. This is all about the WBC. The next one is platelets are the thrombocytes. Nucleus is absent. Remember one thing: platelet does not have any nucleus. Okay, memorize this. Is they mostly ask in the Viva. Does platelet contain nucleus or not? And this is the smallest form element, that is the size 2 to 2.5 micrometers. And if we say for the content of plasma platelets membrane, that is thromboxane A2, prostaglandin, leukotrienes, platelet activating factors, cytoplasm contains granules, dense on the alpha granules. Normal count is 1.5 to 4 lakhs. Okay, and the destruction takes place in the spleen. Okay, like other cells of the bloods. Thrombocytosis, surgery, injury, childbirth, splenectomy, and stress like this. What happened? If there will be splenectomy, spleen get rupture or the not spleen present, there will be the increase in WBC and RBC also increase. And why should not platelet also increase? Okay, stress causes increase in the surgery, injury, and childbirth. Okay, surgery, injury, platelet count must increase because platelet are responsible for the coagulation of the blood. If they are not present or the in less amount, how they will get how they go the process. Okay, so that's why increase in cytopenia, thrombocytopenia, bone marrow depression. As I already saw this, hypersplenism is spleen is get enlarged. That means there will be more phagocytosis of the platelets. Okay, during hypersensitivity, drug hypersensitivity, not during drug hypersensitivity. Okay, HIT is the heparin induced thrombocytopenia. What happen actually? Heparin get attached to the platelets, and our body system think is a foreign and get phagocytosis like this. Platelet count decreases. That is called HIT. Okay, heparin induced thrombocytopenia. And this is fragmentation of the megakaryocytes which is present in the bone marrow, and that is called giant cell. Okay, and then if you say about the function of platelet, that is the primary hemostatic block formation by the platelets. And if you want to learn about the process of platelets, that is adhesion, activation, aggregation. You should not if you get confused about this, then you should forget it. It is for higher classes. And like this, what happens in platelet contains is glycoprotein 1a 2, okay, glycoprotein 1b. These are responsible for the, and this is bone equilibrium factors responsible for the adhesion. Okay, and there will be the release of some chemical mediators like thromboxane A2 and ADP. They are responsible for the requirement of other platelets, that is called the activation. Okay, and the final is aggregation. Aggregation means what? Aggregation of the platelets. And there the receptor like what? GP2B and 3A, glycoprotein 2B and 3A. These are the receptor present on the platelets that are responsible for the aggregation. Okay, like this you will study in the higher classes, and this is actual function of the platelets. Let's see blood grouping. Blood grouping is the ABO blood grouping, RH blood grouping, M or N type of blood grouping. There are many type of blood grouping. Cali, what are the? I forgot about this. Okay, so let's see ABO blood grouping. ABO blood is based on the presence or absence of A or B antigen on the surface of RBC. It is divided into four categories, and the father of the blood grouping of ABO is Karl-Steiner, and there is a law of Karl-Steiner. You should know this. If the antigen A is present, then the corresponding antibody is absent in the plasma. Okay, similarly, if antibody of A is present, that is anti-A antibody, then antigen A will be absent in the plasma. This is called Karl-Steiner and nothing else. Okay, there are blood groups AB, and O, where the antigen A and B are absent. Okay, absent mostly. O doesn't have any antigen. That is called O blood group. Okay, and there is like this, you know this about RH blood grouping, which RH antigen present in the RBC surface. If it present RH positive, we absent RH negative. There is no as such natural RH antibody present in our body. Okay, it is induced by the RH antigen. If there will be something like mismatch blood transfusion or something like that, what happens in the erythroblastosis fetalis, we'll discuss in the further classes. And if you say about the blood grouping test, that is slide agglutination test, we will take 3 drops of blood, adds the different antisera like antisera A, antisera B, and the antisera D, and they will be based on the coagulation, not coagulation, you should not say coagulation, like agglutination. Okay, based on the agglutination you will say whether blood group is AB positive, A positive, or like this. Okay, let's see one of the important clinical application of the RH blood grouping, that is RH incompatibility. Whereas the erythroblastosis fetalis, when mother is RH negative and the first child is RH positive, then in second pregnancy if the child is again RH positive, that time RH incompatibility is results. Generally it doesn't result. Okay, like this condition fulfill, then there will be the erythroblastosis fetalis, otherwise not. Okay, so let's what I have written there. Okay, during the pregnancy or the parturition, the fetal blood is mixed with a maternal circulation in some amount. Okay, that small amount is enough for the production of antibody, that is RH antibody or the anti D. Okay, anti D antibody is produced. So in subsequent pregnancy, and that is IgG type. And also you know that IgG has a power to cross the placenta. Okay, that's why happened. And so second pregnancy with a RH positive child, this antibody cross the placenta and kill the fetus by antigen antibody reaction. Okay, you know this placenta cross and the kill the fetus. Okay, like this happen. Kill, if may not be killed, then very dangerous condition. Erythropoiesis is very dangerous one. Okay, so clinical feature is what? Cardiac arrest, bilirubin react with brain. Okay, reach to brain rolling, and hemolytic anemia will be present, and there will be the jaundice and the swelling of the livers like this. Over the symptoms of the RH incompatibility, and treatment is the injection of the RH antibody immediately after the delivery of the first child. Okay, if we will give the delivery of the first child, if you know this can may happen, then if we give the injection, then there will be no production of the antibody. Okay, that get destroyed in the body. Okay, so but there is why concept why again the RH mismatching is happening, but ABO not in the child, because the antibody against the ABO antigen is IgM type that cannot cross the blood-brain barrier. Okay, that's why they're not. Okay, so this is simple one. Okay, and if you say about the uses of the blood grouping, that is blood transfusion reactions, and we already know in pregnancy, RH incompatibility, investigation case of paternity dispute, and the medical legal value. Okay, so if paternity dispute, if so it's something like what happened actually that if that means if mother blood group is one and father blood group is one, then we see the what the blood groups of the child can be possible. If the child blood group is coming under this, then we can say that the child is these two parents, maybe this one. If not possible, that there may be some other dispute, okay, like this we can, but not is the one confirmatory one. Okay, this is not the confirmatory one. This give the possibility. Let's see the mismatched or incompatible blood transfusion reaction, one of the most hazardous of the blood transfusion. Okay, if there will be mismatch, this may cause a very dangerous one. Okay, a mismatched blood transfusion occur when patient receive blood from a donor whose blood type is incompatible with their donors. Okay, example rahila. Okay, receiver is okay, recipient is the O negative blood group and if donor is A positive blood groups, then the anti-A antibody will attack the Vatikra. Okay, like this immune mediated, non-immune mediated, immune mediated hemolysis, non-mediated circulating overload, and acute and delay type. Okay, and the rapid hemolysis injected RBC destroyed in spleen post trauma transfusion injury. Jaundice is the kidney failure because of the hemoglobin, free hemoglobin destroyed like this. Okay, hematine divided in the nephron kidney damage and circulatory overload, excessive transfusion causes cardiac overload will be present. Yes, if we given the excessive blood to the body that cannot capable of the heart, so heart what happened? Heart will not able to the utilize the gate function like. Okay, then the concept is trally. Okay, trally is nothing but transfusion related acute lungs injury where there will be the edema of the lungs. Okay, pulmonary edema, fluid retention will be there, allergic reactions, and also one new things I haven't written here, that is transmission of the some diseases like hepatitis B, AIDS. This can be possible by the blood transfusion. Okay, so be cautious about this. Let's see next one, that is hemostasis, spontaneous arrest of the prevention of bleeding by physiological process is called hemostasis. Mechanism of contraction of the blood vessels, formation of fast hemostatic plaque, conversion of primary to secondary or the temporary to permanent one. Okay, what happen actually, see injury to blood vessel, there will be a release of serotonin causing vasoconstriction, local margin. Okay, these are all the vasoconstriction constrict the blood vessel of the injured one. Okay, and also one thing is what happen, let's see this injury to blood vessels, endothelium is disrupted. If endothelium get disrupted, there is the exposure to collagen, and collagen is the responsible for and collagen also BWF is present there, that causes attachment of platelet. There will be platelet adhesion, then platelet activation, release of the certain granules that attract other platelet. Okay, and there will be the aggregation of platelets that causes the formation of temporary plaque of the plates or the primary hemostatic plaque. Okay, and similarly what happens, this injured blood vessel release tissue thromboplastin that causes extrinsic system, and via the intrinsic system causes activation of coagulation, and coagulation causes fibrinogen to fibrin. Okay, this fibrinogen to fibrin will get deposited in the primary hemostatic plaque that get converted into the secondary hemostatic plaque or the permanent clot. Okay, like this happen in the hemostasis. And I haven't discussed about the clotting mechanism, we should learn in this book. Okay, I haven't discussed that. That is also one of the important question. Okay, why blood does not clot in the circulation, that is presence of natural anticoagulants like heparin and protein C and S. These are responsible for the not clotting of the blood, and also velocity of circulation. If there will be slow or sluggish blood flow, then may causes the okay coagulation, otherwise no process of coagulation. Okay, presence of fibrinolytic system. Okay, one thing is what fibrinolytic system. Okay, fibrinolytic system is what happens if there will be excessive fibrin deposition in the blood vessels, they may causes coagulation or intravascular coagulation. Okay, so that is prevented a fibrinolytic system. Fibrinolytic system is nothing but, okay, there is a one enzyme called plasminogen. Okay, plasminogen is converted into plasmin by the tissue plasmin activators, that plasmin break down the excess fibrinogen. Okay, that is actually the mechanism of fibrinolytic system. Okay, so this fibrinolytic system is one of the most important mechanism of our body to prevent the intravascular coagulation. Okay, and also smoothness of the endothelial lining prevent platelet adhesion. If the endothelium is smooth, there will be no ruptures, and generally there will be no platelet adhesion. If there will be no platelet adhesion, there will be no primary plaque formation. If there will be no primary plaque formation, there will be no secondary plaque formation, and there will be no clots. Okay, like this, why the blood is not coagulated inside our body. Okay, this is important about the hematology section. And most of the question will ask from this what I have covered, and most important are the anemia, jaundice, erythropoiesis, and megaloblastic anemia, iron deficiency anemias. Like this question, most like blood transfusion reaction is also important. ABO blood grouping and the important is what erythroblastosis, fetalysis. Like this mostly asked. Okay, and also neutrophilia, neutropenia, and this is one of the important for the Viva point of view, and also in the exam they will asked. And thank you very much.